going to start another session. I'm going to talk about comorbidities and mortality improvement, new ASMBS and IFSO guidelines. Here we have with us to debate Dr. Ali Aminian, Professor of Surgery and Director of Bariatric Surgery at Cleveland Clinic. Welcome. And Dr. Giuseppe Navarra, the elected president of the Italian Society of Bariatric Surgery. So we will not lose much time. We will start calling out my friend Maurizio De Luca, that is the Director of Department of Surgery, Rovigo Hospital, Italy. He's going to talk about the systematic review of the new ASMBS IFSO guidelines. Thank you, Maurizio.
Thank you, Gaetano. Thank you, Ali, and thank you, Giuseppe. And it's my pleasure to show what we did until now. First of all, this is my surgical disclosure. And go ahead with the pyramids of evidence. I want to point out that in the lower part of the pyramids, we have the case reports, the narrative review, expert opinions. So my opinion is versus the basis of the pyramids. Then we have case control studies, court studies as observational studies. Of course, then we have randomized control trial, and then we have systematic review and meta-analysis. So the role of systematic review and meta-analysis is an important role. When you add at this role the comment after the evidence of the expert, you can elaborate guidelines. But we need the evidence to discuss. We cannot discuss today without evidence, because if we discuss without evidence, we are here. If we discuss with evidence, we are here. This is the difference. So, systematic review and meta-analysis are epidemiological types of studies which do not provide new data, but they have a great importance. They allow to have a summary picture of the scientific evidence present on a particular topic. Particularly, the systematic review summarize and collect the result of all available medical studies and RCT, and can provide vital information about the effectiveness of an intervention. While meta-analysis is something more, not only summarization, but an analysis of the paper and comparison between the papers. So the results are more, have a small higher level of evidence. Of course, it depends on the studies, but not only the design of the studies, but also the quality of the studies. I can have an RCT with 10 patients considered and with 6 months of follow-up. The quality of that paper is a very low quality. I can have an RCT with this homogeneous BMI or this homogeneous age of the patient. It has a low level of quality. So it's important not only the type of the design, but also the quality of the design. A rigorous meta-analysis is a great approach to evidence-based medicine. So we know our ASMBS IFSO guidelines. They started, as we know, from the old 1991 National Institute of Health consensus statement, and it was evaluated that in the last 30 years something changed. So dominant procedure at that time were VBG and Roux-en-Y gastric bypass mainly in open, while today we know that some operations have abandoned and we have some new operation. So we, according with the board of ASMBS and IFSO EC, decided to update the guideline with a better methodological system. We asked to some methodologists who suggested us to do, of course, prismas, and after prismas for every topic, to decide if do a systematic review or a Delphi. It's very difficult in this moment to go ahead with a grade 2 for this kind of indication, the majority of them, because they are new indication, so the literature is not robust and the grade process could be very, very difficult. So at this stage we can do mainly systematic review regarding the topic of ASMBS and IFSO EC. So we started with our prismas regarding topic BMI 30-35. The prisma consent us to go ahead with the systematic review. Regarding BMI 35-40, class 2 obesity, there are no data. So we define two Delphi rounds in order to express a recommendation. Regarding BMI threshold in Asian population, okay, the systematic review. Regarding older population, okay, the systematic review. Regarding pediatrics and adolescents, very good systematic review, very good. I mean, there is a robust literature regarding this topic. Joint arthroplasty, some studies not in favor of metabolic bariatric surgery before arthroplasty. So we perform a systematic review which is in favor of metabolic bariatric surgery before arthroplasty, but also a Delphi in order to reinforce, give more force to our recommendation. Regarding abdominal wall hernia repair, okay for systematic review. Organ transplantation, okay. BMI more than 60, okay, the systematic review. Cirrhosis, okay, the systematic review. Heart failure, okay. Of course, as you can see, we can say this after the prisma for every topic. And multidisciplinary, okay, but then I show you something more. Revisional surgery, heterogeneity, but okay, systematic review. So in synthesis, this is what we did regarding every topic, mainly systematic review, so with a methodological good process, which is in higher part of our pyramids, in some cases Delphi. So, of course, these are the results of the systematic review and the correspondence, but I have to say you that these results are not approved. But as you can see, regarding the guideline published in the last November, we have quite often a good grade of recommendation. B regarding 3-35, D regarding 35-40, B regarding Asian, B regarding older population, grade B regarding pediatric and adolescents, B regarding arthroplasty, and again, people with obesity abdominal wall recommendation grade B, solid organ transplantation grade B, BMI more than 60 grade B, cirrhosis grade B, heart failure grade B, multidisciplinary grade B, revisional grade B. But I have to say you that this is a grade of recommendation which is related to the evidence. The role of the expert is not completely defined. After the role of expert who approve this kind of recommendation, we need the approval of the board of IFSO and the board of IFSO. So everything needs to be approved. Thank you.
Microphone. Is it okay? No. Okay, now it came back. Okay. Maurizio. Very good presentation. Would you like, I would like to make one question, if I could, before my colleagues here. So we took 30 years to do this. How long do you think, with the volume of information we are getting today, and the capacity to absorb all of this information, should you think should be done these guidelines? For 5 years, 2 years, yearly, 10 years?
No, I think I am optimistic because I am like because I work with the methodologists And I know that for some topic we can do something more in terms of evidence. First of all, I think that these guidelines in 3 years can be already updated. Yes.
Please. I think your mic is on.
Great presentation and great effort by your team to do all this analysis. Can you explain why do we need to grade those statements that have already been published? What's the importance of grading those and sharing those grading with in the medical literature? Just a basic fundamental question.
The grade is a platform which gives us the possibility to identify the quality of a single paper. So, considering the quality of a single paper, independent from the design type, we can exclude some paper. So, at the end, the evidence given by the grading is, by the grade 2 particularly, is the best evidence that the methodologies suggest us. Of course, we are in a different situation because some topics are all topics, okay? Elderly, adolescent, but some topics are new, and the literature is very poor. So the grade, in that case, fails. And the methodology says, okay, if you want to be correct, in this moment, you can give this grade of evidence. It's enough. You are in the right situation. But I know that regarding adolescents, we can do something more. There is something better. But not in all the items. Not in all the items.
That's a good point, but it's like a double-edged sword, because if we come up or you come up with some low grading for some of the statements, if we end up having some grade C or D of evidence, then that may hurt the field and the original statement. So hopefully most of the statement gonna get grade A or B, but I think some may be classified as low-level evidence, C or D, and then that may hurt the whole document and the purpose.
No, of course, the role of the expert is very important in this phase with the evidence that we have. So, I several times during my presentation said that we can modify, but we have to write the motivation because we modified. For example, the grade methodology for the European 2020, for the European guidelines, gave for the post-operative follow-up a low level of evidence. But the community of patients from German suggested that it was very important. So we upgraded the grade. From C became A, but we wrote the reason. For this reason, we can do this, but we have to motivate what we decide.
Okay. This is Giuseppe, per favor.
Just to clarify better what Maurizio said, we have been engaged in Italy with developing the new guidelines following grade, because our Department of Education and Health requires this grade system to be put into the Italian national system of guidelines. Otherwise, it's not accepted, it's not published, it's not available even for medical legal reasons. So you need to know the process, because if you don't know the process, this is where you can end up with.
Yes.
So you need to know the process and what can be the advantage and disadvantage of each PICO, each question. You need to know everything, and you need to know the process. Now, Maurizio has been really deeply involved almost every Monday for the last 2 years on this topic. So he probably is the one that among the community, at least in Italy, but I think not just in Italy, know all the details and all the secrets not to be, to go wrong.
Thank you, people.
Fantastic. Thank you very much, Maurizio. This is a topic maybe we could spend the whole afternoon talking about, but we have to go along. I'd like to call now my dear friend, John Morton. John is He's going to talk about long-term all-cause and cause-specific mortality improvement after bariatric surgery. John is Professor and Vice Chair, Quality Division, Chief Bariatric and Minimally Invasive Surgery at Yale University School of Medicine.
Thank you, Caetano, and thank you to all the moderators and for the opportunity to be here at IFSO. It's a beautiful city and a great conference, and these are important topics. I really appreciate the last discussion because we can create these guidelines, but if we don't have buy-in, then it's for naught. So it is important that we talk to the payers to make sure it happens. I'm going to talk a little bit about long-term survival associated with bariatric surgery. Here are my disclosures. So I'll talk a little bit about what's the evidence base that we have for ASMBS and IFSO indications. What's the magnitude of benefit? Really interesting, most recently, we can now tell which of the procedures renders more or less of a survival benefit. And some intriguing new studies that show there are some things that we can do to modify mortality on the side of bariatric surgery. So this is the leading causes of death in the United States. And you can see there that bariatric surgery gets a check mark, and 7 of those 10 are improved. Thanks to Ali's study about COVID, I think it's around hospitalization, but ultimately I think we will see a mortality advantage. Where we don't get necessarily a check mark yet is Alzheimer's disease, but we might, because one of the biggest risk factors for Alzheimer's disease is diabetes. So that may have some impact down the road. Can't do much for COPD, damage is already done. We can't necessarily help that. One place where we definitely get an X, though, is around what's called accidents or unintentional injuries, and this is truly drug abuse as well as suicide, and unfortunately we have seen increases in that for the bariatric surgery population, so we always need to be aware and vigilant and educate patients around that. These are some of the studies that have been done over the last year. This is a very good one, which is a meta-analysis, and you can see there that clearly there's a preponderance of evidence supporting bariatric surgery is improving long-term survival benefit for our patients. The Artaban study I thought was a very good study to include because it addressed a population we don't usually address in bariatric surgery, and that is older and sicker males. This is the VA, Veterans Administration population out of the US, and it is 98% male. So you can see here there's still definitely a clear advantage to having surgery versus not having surgery. All of this gets translated into roughly an additional decade of life. And as I'll share with you, not only will you increase the quantity of life, but the quality of life will improve as well. This is another meta-analysis that was published in Lancet. I really want to thank our medical colleagues for being part of this. Carell, I think you were on this. So, kudos to them to put together a paper that showed a lot of support for bariatric surgery, and that's exactly what they demonstrated here. I think one thing was telling, and hopefully it shows up here, is that they put it almost in a numbers needed to treat manner, and I'll kind of read it. It said for every 1% increase in utilization rates for bariatric surgery, we could yield an additional 5 to 6 million life years. Pretty impactful. So that's, I thought, a great message from that paper. Here, another paper, a commentary around this paper did demonstrate that I think an important concept. One is what we do is pretty amazing, has great improvements, but we can't undo everything. There may be some burden of disease that will be difficult to unlock and unload through surgery alone. And that's what the comment really pointed out, is that there may be some residual disease left after even our bariatric surgery. Much as we have pack year history for smoking, perhaps we have pound year history for obesity as well. So what does it call for? Earlier intervention. These are the original studies. We owe a great debt to Dr. Nick Christou for his study that first demonstrated survival benefit. Dr. Porres did have a paper in 1995, but it was tangentially related to survival. This is the first population-based study, and he also demonstrated that. Of course, the story about bariatric surgery cannot be written without the initials SOS, and you can see there that they also demonstrated improvement. A couple of things that are worthy to look at here. One is regardless of procedure, and frankly, any type of therapy, after the first year, there's a natural increase. You see that even with the new drugs. That is an adaptation that patients will have. This is the Ted Adams study. Ted is a great epidemiologist from University of Utah. He was our Mason Lecturer the year I was president for ASMBS because I really enjoyed his studies. What he demonstrated, of course, was almost a 90% reduction in 5-year mortality related to diabetes, and overall reduction of 40%. Pretty remarkable. When these surgical oncologists and other oncologists get together, they're happy if they see a 5 to 10% improvement. This is 40%. And it's just so powerful when it comes to diabetes. And he followed up the 5-year study all the way up to 12 years now to show there's enduring benefit to the procedures. Couple of other things to look at here. Number one killer in the US is still cardiac disease, and a couple of studies here help look at this in a special way. On the left-hand side, you can see another meta-analysis about the impact that bariatric surgery has on MACE. I think there was a lot of attention recently about the SELECT trial for semaglutide that showed reduction of 20% mortality, or about adverse events following that drug. And here you can see similar and even greater impact with bariatric surgery. But the one on the right that Ali was a co-author on, I thought was really important because it showed the impact it has on, again, an older population, but some really big reductions in mortality in people that had severe cardiac disease, 37% reduction. Really a big highlight, 54% reduction in heart failure. Heart failure is such a big issue in the United States. It's a big cause, people being readmitted, a big spend as well as we talk about money. But intriguing results here, especially around heart failure. And we know that the obese are particularly at risk for that, even the right-sided heart failure, or along with the traditional stuff like HEP-HF. This study is from Ali that also demonstrated, this is Ali here. You can see that this is from the SPLENDID trial. The one thing I want to point out here is that you need to have much more than the 5 or 10% weight loss we associate with improved clinical benefit, when it comes to high blood pressure, diabetes. Here, the threshold is probably at least 25%. Now, survival benefit, it came up originally that most of the survival benefit that we were seeing was probably related to diabetes, and that was what some of the original studies showed. But as we move forward, it does look like there is better survival benefit for those that have diabetes, as demonstrated in the left-hand side, but also on the right-hand side. The SOS trial followed up its data, and they showed that there was pretty much equivalent benefit. So the diabetics do improve, but so do the ones who don't have diabetes. This is Ali's study too. Maybe we should pause and give Ali a round of applause for... I give a talk about the future of bariatric surgery, and I call it the 7 S's, and the first S is science, and he really is bringing forward the science that's so important for us. Here you see the impact that bariatric surgery has had on NASH outcomes. Of course, the liver-related deaths go down, but the number one reason patients with NASH die is because of cardiac disease, because the risk factors for NASH are the same as they are for heart disease. In other words, things like diabetes and metabolic syndrome. I want to point out a very brave study that came out of this country that are looking at the results from the biliopancreatic diversion. And in this, they had a 15-year results, and this is where the BPD was invented. But they showed, at least in this particular population, that there were more patients who were alive that did not have surgery. Recently in the news, Lisa Marie Presley, Elvis Presley's daughter, passed away, and there was a lot of talk about what kind of procedure she had. And you can get the autopsy report. I ordered it, and I got it. And so what you can see there, she died from massive small bowel infarct. 900 centimeters of her bowel died. And she had, it looks to be, either a DS or a SADI. It's hard to tell exactly what she had done, but there was a connection there. I point this out because this study is the first one, and it was just published this year, to look at the differences in mortality amongst procedures. I want to highlight this. Believe it or not, here you can see that the procedure that had the best outcome for life expectancy, and this surprised me, was the sleeve. And actually, at least in this study, DS had a negative impact on survival benefit. It's something we have to keep our eye on. One of the reasons that you may not see as good why the sleeve may be better is because of alcohol use. And on the left-hand side, you can see the sleeve doesn't have this problem, but the bypass does. I did some of the studies on alcohol a few years ago, and thank you. And so you can see here that if you have a bypass, you're going to have less tolerance to alcohol. It has to do with alcohol dehydrogenase. The more receptors you have, the better, and when you bypass them, it doesn't work as well. Finally, you can see here that with the last study that this is not a problem specific to bariatric surgery. You see this in stomach cancer patients too. I'm going to close out with just a couple more slides here. We need more RCT data for survival benefit, at least to satisfy our colleagues in the Italian Health Ministry. But one thing that we can see for sure, at least in the RCT from 25 years ago, that there was a survival benefit with the POSH program that Henry Bookwell put together. What about other surgeries? Do they have survival benefit? Total joint replacement was about 3%, and it was gone at 12 years. Coronary artery bypass for people that have heart failure, no survival advantage at all, and those are paid for easily. What can you do to improve some of the mortality? This one really caught my eye. With at least 10% total body weight loss, you can reduce mortality by 40%. And this is from our vaunted MBSA-equipped data, which is over 500,000 patients. We recently presented that it is easy to accomplish that 10% weight loss goal, particularly when medications are employed. You can get a 10-fold improvement if you have medications on board. Lastly, this was an eye-opener for me. Volume matters. We know volume matters when it comes to leaks and deaths, but not survival. This was a terrific study from the Nordic Obesity Registry, and they showed for the more cases you do, the more survival benefit you have. So I'll close with saying that we know that it does increase life expectancy, big benefit for diabetics, reduction in the 3 Cs. Got to be careful with some younger patients and those with alcohol issues. And there are some things that we can use to our advantage, namely doing more cases and getting patients to lose some weight prior to surgery. Thank you very much. I appreciate it.
Fantastic, John. Ali, would you like to start? Because
yeah, sure. Thanks
almost 30%.
Thanks for a nice comment, John.
You write the studies.
Yeah, I appreciate that. So, a great talk. You briefly mentioned about the SELECT trial, the role of semaglutide on reducing the risk of death or MACE event, major adverse cardiovascular event, which included heart attack, stroke, and death by 20%. So we're going to hear more about that in November. They're going to present the data in American Heart Association. But 20% reduction in MACE is great, is phenomenal. That was seen in the setting of randomized clinical trial. All the studies that you showed us were observational data, but the findings were consistent across the board. So we have almost 40 well-matched observational studies that consistently, all of them show benefit of the surgery in the range of reduction in mortality in the range of between 35, 40, 45%. All the findings were consistent. But the critique is that all the data we have come from observational studies, not the randomized clinical trials. So how can you answer to that critique of lack of RCTs on showing the benefit of bariatric surgery?
Well, I mean, there's a lot of different ways that you can show causation along with association. One is, biological plausibility, preponderance of evidence, all that's present there. I will say that we do have a lot of randomized trials in bariatric surgery. It's time to pool those trials together and show the survival benefit that's with it. I think it's going to be difficult to create a trial just to show mortality because it takes time and it takes numbers, and we probably won't have that time to do that. And I just demonstrated that no other field of surgery has even come close to showing what we do when it comes to survival benefit. And I think probably the answer is to pool some of those RCTs. That's probably where we should be.
Yeah, good point. And again, briefly mentioned that yesterday in another session, that it's very, very difficult to randomize patient to surgery versus no surgery. It's not like drug A versus drug B. It's not like drug A versus placebo. So you need to randomize thousands of patients, 10,000, 15,000. So in the SELECT trial, they had 17,000 patients, and they were followed for 5 years. So randomize thousands of patients to surgery versus no surgery and follow them for years to see the mortality benefit or hard clinical endpoints it's awfully expensive and not practical. But pharmaceutical companies have spent billions of dollars on those trials. We don't have that money in the surgical field, so probably that's the best data that we can get.
I agree. I don't think you're going to see the NIH funded, especially after the Look-Ahead trial that yielded such little benefit. And you know, it's different. Like companies like Novo, you know, its profits rival the GDP of Denmark. So they've got plenty of money to put behind it. We don't have that kind of champion right now in bariatric surgery, but we do have one good thing, and that is what we do does work, and that's been demonstrated with these studies. There's been a lot of like smaller RCTs. We should pool them together, and I think we probably can do that.
Thank you.
Thank
Great.
you.
Giuseppe, would you like to make any comment? Okay, so thank you very much, John.
Thank you.
There's a lot of things. Afterwards, I'm going to ask you a lot of things. So now, I would like to call Rachel Moore, another dear friend from Rose Medical Center, Denver. And she's going to talk about factors related to weight loss, maintenance in the medium long term after bariatric surgery.
Good afternoon. And I wanted to sincerely thank you for this assignment. I had a lot of fun with it. We had two hard academic speakers, and where my mind went with this was, what can I change in my medical practice to help my patients do better in the medium and long term? And so my thoughts around this, as I said, I had a lot of fun with it. I hope you find it useful. These are my disclosures. So within this subject, first of all, we have to define success. What is success? And in order to compare different, and you're going to see me in the next 10 minutes, try to compare different papers with different endpoints and study results. And first of all, we have to decide, what does success mean? What is the definition of medium and long term? The most common definition of success after bariatric surgery that I encountered in my reading was defined as losing more than 50% of your excess weight. But calculating excess weight requires that we define ideal. And even within the room, I'm sure we could have an argument about whether, do we really agree that a body mass index of 25 is ideal? Most of our patients don't reach a BMI of 25. Even our most successful patients, they get into the overweight category between 25 and 30 at their lowest, and then they come up a little bit. And so many of our successful post-surgical patients still have a definition of class 1 obesity, and so defining success here is difficult. And we also need to acknowledge that patients can have dramatically improved health and quality of life without hitting that metric. So it's interesting to think about. And I discovered 5 things that were relevant issues to a patient's medium and long-term success after bariatric surgery. I wanted all of them to be things we can change, but they are not. Age, what I called participation, BMI, physical activity, and psychological factors are going to be what we encounter here. And I pulled a couple of papers for each in order to stay within my limited time. In this paper regarding age, Contreras et al. Had 337 patients. They divided them into higher and lower than an age of 45 and discovered that the younger group lost more weight than the older group. That's not really all that surprising, but they also discovered that gender, body mass index before surgery, and whether the patient had bypass or sleeve didn't really matter. And so that was more interesting to me than the fact that being younger helped, which was unsurprising. In this group, with a retrospective study of 500 consecutive patients, they divided into more groups. So they did younger than 30, older than 60, and then divided by the decade in between. And once again, weight loss and total number of comorbidities that went into remission were both significantly higher in younger patients. Switching to what I call participation. In the literature, this is often called compliance, but I think that's a little judgy. And so I declared it to be participation. How much you get to see the patient after their procedure. This study showed the impact of routine and long-term follow-up on weight loss. It was a retrospective of 385 patients with up to 5 years follow-up. Group 1 attended every post-op appointment. God bless them. Well done. And Group 2 were the patients that were lost to follow-up. Excess weight loss was statistically significant between Group 1 and Group 2. For sleeves, Group 1 lost 78% and Group 2 lost only 39%. Bypasses were more durable even if they weren't seen again. So the bypass Group 1 lost 75% and Group 2 lost 62%. And again, on my clinical mind is like, oh, you know, maybe I need to check on sleeves more than bypasses. You know, I'm always trying to develop what should I change in my practice. There was a significant difference between how sleeves did when they didn't make their post-op appointments. In this study, it was 172 patients that had adjustable gastric band, and it starts to reference back to some of my other categories as well. They were trying to, you know, when this is compliance that I was calling participation, and when patients don't come to their appointments, we like to say it's the patient's temperament. The patient had a personality disorder. They were non-compliant, and so I thought this was charming because it said, okay, well, let's take a look at let's do some testing and let's identify the personality disorders and follow this forward. And they discovered that body mass index, compliance, attendance at scheduled visits were all significant. Having a narcissistic personality only mattered at the 1-year mark, and then with later follow-up, the personality disorder didn't matter anymore. So percentage at 48 months, only the percentage attendance at scheduled visits mattered. So even for your most difficult patients, if you can get them to come in, you may be able to save their, help them have their best result. Body mass index, another thing that we can't control. This is from, I don't know if internationally you all are as familiar with the Michigan Collaborative, but it is big numbers, and some very, very interesting papers have come out of Michigan in the US. This was retrospective from that important Michigan database, 27,000 patients who had bariatric surgery, and when we were talking about defining success, 36% of them had a BMI below 30 at 1 year after the surgery. And then they started to break out, like who did well and who didn't. Predictors for success: patient having a body mass index below 40 when you did the surgery in the first place. Having had a sleeve bypass or switch, not an adjustable gastric band. And then I highlighted in yellow because I think it's really, really relevant. In a patient whose body mass index was greater than 50, only 8.5% had a BMI below 30 at 1 year. And the quote at the bottom I pulled out directly from the paper because I think it's just excruciatingly important. The paper says policies and practice patterns that delay or incentivize patients to pursue bariatric surgery only once their BMI is highly elevated can result in inferior outcomes. And we all know this, but it's a very strong statement to have the data published. Another paper showing predictors of risk and success. Age at onset of obesity and years of obesity did not affect outcome. I remember when I started, I'm in my 21st year, so I can refer to like 2002, 2003, and we used to ask every new patient whether they had been big their whole lifetime, how many years they had had obesity, and at least in this paper, that's not proven to be very important. Age, pre-op BMI, and the Edmonton obesity staging all predicted success. High BMI patients had lower weight loss. Older patients had lower weight loss, and so we're starting to see the same over and over again. I like this one because this is one where I can intervene. Physical activity, it's also, in my experience, the part of lifestyle change that patients try to weasel out of the most. And so here we have becoming physically active after bariatric surgery is associated with improved weight loss and health-related quality of life. 199 patients who were at least 1 year out from their surgery. A questionnaire was used that divided the patients into whether they were inactive or active based on 200 minutes a week of physical activity. And then they split them into 3 categories. So they had patients that were active before surgery and active after surgery, inactive before surgery and active after surgery, and then inactive before surgery and inactive after surgery. And the patients that were inactive before surgery and active after surgery, and the patients that were active before surgery and continued that physical activity habit had similar weight loss. But the patients that were inactive before surgery and active after surgery lost more weight than the patients who continued to be inactive when they were inactive before surgery. And unsurprisingly, again, the patients with physical activity scored higher on general quality of health and mental health domains as well. So both good for weight loss and good for mood and mental health. Another study about physical activity and gastric bypass. And in this case, they assessed physical activity and measures of depression and mental health, and they discovered that the intensity of physical activity was associated with better weight loss, but both frequency and intensity were associated with improved mental health. Psychological factors. These are behaviors in this study. Sheets et al. Showed behaviors that are associated with a poor prognosis after undergoing bariatric surgery include substance use, binge eating, grazing or snacking, and nocturnal eating. I'm hoping in my patient population to ease these some of these symptoms with anti-obesity medications and appetite control, and I use that liberally. In this study, which showed predictors of weight regain after bariatric surgery, independent predictors of regain were things like thinking about food all the time, severely decreased postoperative well-being. We've all seen the patient who has a crisis in their life, their spouse dies, they lose their job or whatever, unfortunately in that critical year right after their bariatric surgery, and this affects a patient's ability to be successful. I highlighted in yellow because I like things I can affect. Patients that engaged in self-monitoring were less likely to regain weight. And so what should we do? When you've got the patient in front of you, the bigger patient, the older patient, should this affect our choice of procedure, perhaps more powerful interventions for our patients with higher BMIs? Could you choose to emphasize one part of your multidisciplinary program to help a patient who appears to have a weakness in that area? For example, increased psychological support for a patient with depression. Could you, I showed you a lot of evidence that showed that if they follow up more frequently, they do better. And so for a patient who is already at risk for obesity persistence or recurrence, could you arrange to just see them more often and give them more support? And as I said at the top of my time, perhaps we need to adjust our definition of success to include a patient's health and quality of life rather than just the measurable numbers. Thank you very much.
Great speech, Rachel. Very nice. Ali, would you like to start?
Yeah, Rachel, great talk as usual. So I know you have extensive experience on adding medications to boost the effect of surgery, short-term, medium-term, long-term. Can you briefly share your experience in adding the weight loss medications in patients who had bariatric surgery in your practice?
Yes, I don't know how many days you all have been here, but we all start to say the same thing over and over again with hot topics, and this is one. So I have a completely unoriginal thought to say that the GLP-1 agonists seem to be best. However, I use the more affordable in my country drugs like the phentermine topiramate combination liberally because that's what patients can afford, and it does help cut appetite. I think the most interesting question here to me is about timing. I had early on, when I was doing obesity medicine board certification, I had an endocrinologist kind of endocrinologists are rarely aggressive, but I had an endocrinologist kind of challenge me and say, if you believe in this, then you should be offering them, from day one. Like as soon as you meet the patient, you should put them on anti-obesity medications, and they should be on them the entire time that they're going through their bariatric surgery. I'm not sure that that's true. I'm not sure the data is showing that. And so I think the most interesting question around this right now, at least the most interesting to me, is the timing. When to drop in with anti-obesity medications. And I can tell you on just the lowest level of evidence, as our first speaker, my personal opinion is I'm insisting, although I have helpers in the office, I insist on having the 6-month post-op visit be with me. Because that's my is the patient on track or not? That's my moment that I want to drop in with extra help with anti-obesity medications if they're not where I expect them to be.
If they are not on track at the 6-month visit, then you consider adding anti-obesity medication.
That's what I'm doing right now. But I reserve the right to change my mind as we all learn more about this developing field.
Great. Well, I think everything was said, but I would really like to reinforce what you said about we having concepts of what is failure, what is weight regain. Because we see the pharma, they do big parties just to commemorate 5 kilos, 2 points on BMI. We have patients like 10, 15 years afterwards that had lost 20 and recovered like 8 or 6 points in BMI, and we start thinking, what did I do wrong? So I think we have to change our concepts to show that what we are doing is very important. Thank you, Rachel. Thank you very much.
Thank you.
Well, we should go on. Next is Dr. Karel Leroux. Thank you, Karel.
Well, thank you very much for this
And
opportunity.
he's gonna, sorry guys, it's not only about high blood pressure, bariatric surgery, and cardiovascular disease. Karel is from University College of Dublin.
Well, thank you, and I think this builds on what we've already heard. This is a famous painting that hangs in the London Gallery, you know, of how shocked the Victorians were when new science came about. And I think it really depicts what we as a society is doing outside of these walls, but even inside these walls. So there's some people, for example, you can see our 2 moderators at the front, they're deeply thinking about this new science that we're discussing, the new guidelines, but there's also some people, you know, that are really frightened by the new guidelines and frightened by the new science that's coming up. So we need to understand that our responses, our emotional responses to change is not dissimilar to the rest of society, and we need to accommodate those and work towards, you know, bringing everybody online. We know, this is my conflicts of interest, and we know that we should not do, and I'm glad to see that guidelines are depicting that, we should stop asking people to eat less and move more. Eat less, move more is not a treatment for the disease of obesity. It's not a treatment before surgery, and it's not a treatment after surgery. It is merely a weight loss treatment that does not treat the disease. So that's something that we should stop, as our Sisyphus here is rolling the rock up the hill, but every time the rock gets to the top, the rock rolls down. So understanding that we are treating the disease of obesity is very important. We've seen the SOS study several times already, but we can't stop, you know, thinking about just a long-term weight loss maintenance. And of course, in your clinic and my clinic, what we are struggling with is the small number of patients in percentage terms that do not maintain their weight, but understand and respect that most of our patients have a long-term outcome, and really start you know, understanding that those people that do not respond, they are not people who are weak-willed or have done something wrong. It is a biological response, and even despite our best treatments, we are not able to control all of the different diseases that is obesity. But if we do very, very simple things, and I think that is what we are talking about now, very simple things can have a massive impact. This is the STENO2 study where patients did not have surgery, but they either had conventional treatment for their diabetes or simply they were given metformin, ACE inhibitors, and statins. And if you do that appropriately, you can see the mortality difference that has been driven, and you know, you can see the numbers needed to treat, and not the numbers needed to treat, the numbers of patients enrolled, 80 patients in each arm. Okay? These are not 17,000 patients that required 5-year follow-up. This was simply 80 patients that either had intensive treatment or conventional treatment. So it tells you of the effect size of when we give people good medications like statins, ACE inhibitors, and metformin in this instance. Of course, we've seen this slide many times already. David Cummings. I was not on this paper, John, it's David Cummings that actually drove this. But I also want to make this point that we are focusing on a relative risk reduction. We are focusing on, seeing a 20% reduction, for example, with SELECT. We're seeing 50%, 90%, in some of the old bariatric surgery studies talking about relative risk reduction, but also understand the absolute risk of dying if you, from a heart attack, for example. So what we're seeing on the left-hand side is, what happens in the absolute terms in people with diabetes, and the red line are those people that did not have surgery, and you can see that the absolute risk over 22 years is less than 40%. And that is because we are pretty good. Once you give people statins, ACE inhibitors, and a little bit of metformin, we are very good at keeping people alive. But look now what happens to surgery. The relative risk is very impressive reduction there, but we also see the absolute risk of dying after surgery, if you've had type 2 diabetes, is about 20%. Compare and contrast that on the right-hand side in those patients that did not have diabetes. And what we see is that the absolute risk of dying if you do not have surgery in the red line is less than 20%. But there's a relative risk reduction that we've seen and is very impressive. So the absolute risk of dying after 22 years if you have surgery is about 16%. Okay? But what I want to focus on is look at the patients on the left-hand side who did have type 2 diabetes and did have surgery. Okay? And yet their risk of dying is higher than patients who did not have diabetes and did not have surgery. So actually, giving patients surgery is incredibly beneficial. But I think what we all agree, and I think this is what the guidelines will do, is we need to do better. If this was a report card from school, we would say we need to do better. And I think we can do better because of, the approaches that we now have available. You would have seen our multiple randomized controlled studies, and it doesn't matter if your BMI is above 35 or below 35 in these randomized controlled trials, everybody benefits. And this is the consistency of the data in the randomized controlled trials with surgery. So certainly, level 1A evidence, we spoke about the evidence in randomized controlled trials. When it comes to patients with type 2 diabetes, there's no doubt that it's better. And why is this better? Coming to the gist of what we're talking about, because surgery does not only reduce people's body weight, it does not only treat the disease of obesity, it also treats the disease of diabetes, it also treats the disease of dyslipidemia, it also treats the disease of hypertension. So it's the perfect combination therapy. It's Steno 2 on acid. It's really, really impressive. So we need to stop thinking about surgery as an acute treatment, but start recognizing that it is a perfect chronic treatment. It's a chronic treatment for chronic disease, and hence why it's so important when we do our follow-up that we have a chronic mindset of disease management. Here I'm showing the Gateway study with Carlos Scafon, who is the lead author, showing us that with the weight loss in the lines and the improvements in those patients who have gastric bypass when it comes to the primary outcome is very impressive. So it is continuous, but also it happens before the weight loss. And yes, we have discussed the weight loss independent effects of surgery, as we now recognize the weight loss independent effects of GLP-1. So if we give GLP-1 to people who lose 0% body weight, we still see very impressive improvements in glycemia. We see very impressive improvements in inflammation. That's weight loss independent, as we do with surgery. But when we understand the mechanisms, and I'm focusing here on hypertension, this is work from the Gothenburg group using patients in the SOS study who were randomized either to bypass or VBG. And in this group, this was the randomized controlled trial done by Torsten Olbersch inside. And you can see that, yes, the blood pressure improved, but you also see the increase in sodium excretion. So we see the impact of surgery on organs, such as the pancreas, such as the kidney, such as the liver, as has been shown. So understand, and that of course combines in the overall cardiovascular benefit. What I really think, is missing in some of these conversations is the improvements in inflammation. Because all of you have seen your patients coming in with CRPs of 5, 6s, and 7s pre-surgery, and certainly within months, those patients are running CRPs of 1s and 2s. And of course, if you're thinking about the end organ damage, inflammation is an important driver of the complications, and especially an important driver when it comes to a cardiovascular disease. And it'd be very interesting to see when SELECT is analyzed how much of those benefits that we've seen is actually weight loss dependent, and how many of those benefits that SELECT will bring, is driven by changes in inflammation, changes in also other cardiometabolic factors, etc. So we have an instruction from the American Diabetes Association, the European Association of Study of Diabetes, that when we approach people with diabetes, we are no longer focused only on glycemia. Those circle really reflects glycemia is at 12 o'clock to 3 o'clock position. We have the cardiorenal protection at the 9 o'clock to 12 o'clock position. We have the cardiovascular risk reduction at the 6 o'clock to 9 o'clock position. But note that our colleagues have changed their guidelines. The diabetologists are now instructed in the 3 o'clock to 6 o'clock position to make weight management a primary objective. And I think this is an opportunity for us to reinvigorate the discussion just how good surgery is when it comes to treating people with type 2 diabetes. Because despite all of our randomized controlled trials, we made 0% difference when it came to the number of patients with type 2 diabetes that were referred and actually ultimately had surgery as a percentage term. So please allow me to thank the team at home, and delighted to take some questions. Thank you.
Thank you very much, Karel. Ali, would you like to start?
Great talk, Carl, as usual. So one just general question. Can you explain what's lacking in our data on the role of bariatric surgery for the cardiovascular risk reduction? That was the topic of your talk. So what would be the next set of studies or data that we absolutely need to work on to provide more support? Is that going to be mechanistic studies, or going to be RCT or cohort studies? So what exactly do we need from your perspective?
So I think we need to bring the logic with the emotion. And the reason why we haven't moved the needle is because of a lack of communication. And I think what we are seeing over and over, the biggest block in the system is safety, is perception of safety. And I think the improvements that we have made in surgery and just how safe surgery is has not been communicated in an effective way. I saw some fantastic data that's unpublished, but what was fascinating to me is if you look at systems where bariatric surgery is free at the point of care, it costs the patient nothing, and you combine it with no waiting list. So you can ask for surgery today, you can have surgery in 3 months' time. The ceiling on those populations, and that's mostly the Benelux countries, Belgium, Luxembourg, etc., is only 3% penetrance. So if we actually do everything we do today with all the evidence we have, we cannot exceed 3% of the eligible population wanting to have surgery. And that is not driven by lack of efficacy, it's driven by our inability to communicate just how safe the treatment is. And I think that's going to be important, that we have to go back to the drawing board rather than doing more things, is looking at the data that we had, and I think John showed some great data on that, but communicating that better.
Okay, why have we failed in communicating the safety outcome so far? Or what needs to be done to communicate better the safety outcome to non-surgical community?
I don't know is the answer. I'm not an expert in communication. But I would say maybe we overestimated our ability to communicate. We thought if we say it is so, then people will think it is so. Right? And I think we haven't completely understood just how deeply ingrained the fear of surgery is, And actually, we have not communicated just the amazing improvements that we've made with surgery. And saying to somebody that the risk of dying is the same as the risk of dying of when you have a gallbladder, people go, can I die with a gallbladder as well? Yes. It doesn't reduce the risk of dying of surgery. But saying to somebody the risk of dying with surgery is lower than the risk of dying without surgery, people then have a reasonable comparison. So it's a little bit how we communicate. I think we were defensive in how we communicated, and we need to be, I think, a bit more proactive.
Thanks for sharing your
Fantastic, Carol. Thank you very much. And this is something, I think one of the reasons we have this dying thing is because bariatric surgery back 20, 30 years ago had a bad history on that. Mortality has reduced like drastically, and you're right. I think we're talking a lot about diabetes and all about everything but safety. Thank you very much. This was it will make me think a lot about what you said. So we go ahead. Now we're going to call Dr. Lee Kaplan. Dr. Lee Kaplan is the director of Obesity Metabolism section of Dartmouth Obesity Care Center, Graduate School of Medicine at Dartmouth. And he's going to talk about beyond glycemic control, bariatric surgery, and metabolic disease. Thank you, Lee. Thank you for being here with us.
My pleasure. I can't tell because I just walked in whether I'm late or I'm on time, but I apologize.
Just on time, just on time.
Well, I apologize anyway because I was double scheduled, it turned out. So, I didn't know what to do with this talk because I was asked to talk about beyond glycemic control. So I thought maybe I should give a talk about diabetes. But there are about 100 talks about diabetes in this meeting. So as you can see by the picture that I've chosen for my front slide, I'm going to talk about liver disease. And of course, I know Ali is here, and for me to talk about liver disease and bariatric surgery with Ali here, that doesn't make a lot of sense. So, but I'm going to try to look to the future of the question that we have about diabetes and bariatric surgery. That question is, how much does weight loss cause the improvement, and how much is there a metabolic effect of the surgery above and beyond the weight loss? I won't say independent of the weight loss, but above and beyond the weight loss. And I'm going to use fatty liver disease, or what's now called steatotic liver disease, as the model system to give you a sense of where I think the field is going over the next few years. These are my disclosures. You may have seen them before. So we know that the prevalence of NAFLD and NASH, or now what's called MASLD and MASH, is quite high. And you can see these are obviously, these kinds of epidemiological data are not reliable, but it suggests that all across the world it's huge. And if you look at people with diabetes, it's even bigger. You're talking about worldwide, it's more than half of the people with diabetes. In fact, in our center, it's at least twice as common as diabetes because almost everybody who has severe obesity in a bariatric environment has some form of NAFLD, even if they don't have NASH. And of course, for those of you who don't know, I'm sure most of you do know, you have a normal liver. If you have metabolic dysfunction, then you're overwhelmingly likely to get steatosis. But that steatosis can also be associated with inflammation, which is an immunological problem, and hepatic cell death, which is a combination of an immunological and toxic problem. If you have the inflammation and cell death, you will go on to fibrosis over a period of 20 to 30 years, and fibrosis can progress to cirrhosis. What's not known is whether isolated steatosis goes on to NASH. People used to say it does, but really there's little evidence that very many people will do that. If you have isolated steatosis, you'll probably stay there. A very small percent will go on. If you have NASH, though, you will inexorably progress. You might progress over a longer or shorter period of time. The outcomes that are problematic, of course, are, in addition to cirrhosis, hepatocellular carcinoma, which can occur at any stage, which is why I'm just pushing it to the right. People with just NASH can have a high incidence of hepatocellular carcinoma. And the most common cause of death in this population is cardiovascular disease. I'll show you a little bit about that in just a second. So there are two separate scores for NAFLD. in terms of the histology. That's what's called the NAS score. And that has to do with how much steatosis you have, how much inflammation you have, and how much hepatic cell injury you have. And the scores are listed here, and you can get anywhere from 0 to 8. Independent of that, you have a fibrosis score, which is called a staging score. And that can go from 0, which is no fibrosis, all the way to cirrhosis, which is F4. Now, as I mentioned, advanced fibrosis is associated with all-cause mortality and with cardiovascular mortality. So here we see what the effect is on all-cause mortality. Oops. And you can see that if you look at the cardiovascular mortality itself goes up with advanced fibrosis because the disease has been there for a long time. It takes a long time, and of course, people who have this disease have a very high risk of cardiovascular disease. Now, the severity of the liver fibrosis indicates what the cause of the mortality is in a sense, because if you look at all-cause mortality, it goes up linearly with the degree of fibrosis. If you look at liver-related mortality, it only goes up in fibrosis stage 4. And what that tells you is that for fibrosis stage 3, 2, 1, and 0, the vast, vast majority of the mortality is cardiovascular. Now, we know that weight loss is associated with remission of steatohepatitis. This is a study, I actually showed the results of this study a little bit earlier today. That's the only overlap I have in slides. But I just want to show you that in this study of about 300 patients with very little progression, 61% had F0s, they had no fibrosis whatsoever. The average NAS score was 4.8 out of 8, so they were early in their progression, but they did have significant inflammation and hepatic cell injury. They were given a diet, this is a pure calorie-restricted diet. Anybody who knows me knows that I'm not a big fan of that, but the purposes of showing this particular study is to indicate what simple weight loss with a diet can do. And what they found was about a 4% weight loss, as would be typical. And the change in the NAS score was about 1.6. And what you see here is that they had remission of steatohepatitis, no improvement in fibrosis, but remission of steatohepatitis. And you can see that the amount of weight loss correlated well with the improvement. And that's the reason that, again, I said earlier, that's the reason why we talk about 7 to 10% weight loss as being necessary for this. It's this one study. Well, of course, bariatric surgery, and I'm going to show older data compared to Ali's data, and just emphasize as a preliminary study that this shows that bariatric surgery, in a much less rigorously controlled study, in a very small study, but it showed that in patients who have significant NASH, you can change the NAFLD activity score, the NAS score, from 3 to 4, which everybody had to have to get into this study, down to 0 to 2 over the course of about a 6-year follow-up. So the predictors of improvement were shorter diabetes duration, no surprise there, and greater weight loss, no surprise there. If you look at fibrosis stage, and this was really the first study that convincingly suggested that the fibrosis was going to improve with bariatric surgery, what you see here is that the majority of people, 71%, had fibrosis stage 3, which means bridging fibrosis. 29% had stage 4, which means cirrhosis. And you see how much there was an improvement, all the way to the point where 28%, 6 years, an average of 6 years later, had no fibrosis whatsoever. That's not everybody, but you can see by the distribution here how dramatic the effect was. And the predictors of improvement in severe fibrosis were younger patients than those who improved their type 2 diabetes. Now, why am I showing you this? I'm showing you this because this is old information. But the real question is, does bariatric surgery do something beyond weight loss, or is it just the profound weight loss? Same question we've had for years with respect to diabetes. And so what we saw with the bariatric surgery study, and it's been replicated in multiple other studies, there's an immediate improvement in steatosis. We know that. It's the fastest improvement we get. The effects on inflammation, necrosis, and fibrosis were less clear, but it looked like there was fairly rapid, or at least profound improvement in the inflammation and then the fibrosis may be cleared in some patients, but we don't know how long it took because that was a long study. The weight loss and the other metabolic improvements after surgery provide hope of a benefit, but again, the more recent studies demonstrate that benefit. The effect of surgery to prevent progression of cirrhosis, or to prevent progression, is less clear. We don't have those long-term outcome studies. But what all of the studies of bariatric surgery and fatty liver disease suggest is that the profundity of the improvement in metabolic function and weight from bariatric surgery is what's doing the job to decrease the disease. And as I say, the mechanisms are unknown. So now I want to turn to drugs, because drugs give us a clue about this story. So you know that in 2020, a study of 300 patients with stage 2 or 3 fibrosis, not cirrhosis, were given a treatment of about a little over a year with semaglutide in a daily dose that is the equivalent, from a pharmacokinetic perspective, of 2.4 milligrams. Almost done. The primary outcome, which was resolution of the NASH without worsening of fibrosis, which the FDA requires, was met in 60% of those patients treated versus 17% of those patients who were given placebo. The second primary outcome, which is the alternative outcome accepted by the FDA, was improvement in fibrosis without worsening of NASH. That was not met. There was no evidence that that was done at all in 72 weeks. So the thought was that if you want to improve fibrosis, you're going to have to go longer. But now we have new data. Tirzepatide, a GLP-1/GIP dual agonist, clears liver fat. It clears liver fat by about 50%. So about 50% of liver fat goes away with 52 weeks of therapy. That sounds good, but it's actually not good. And the reason it's not good is because retatrutide in 24 weeks clears all liver fat, 100% of liver fat, in 24 weeks. So it's not that the first one was bad, but what it tells us is that retatrutide, which is a triple agonist of GLP-1, GIP, and glucagon, and the reason I compared it to tirzepatide and not to semaglutide, I've already shown you semaglutide, that's GLP-1. Tirzepatide is GLP-1 and GIP, and retatrutide is GLP-1, GIP, and glucagon. And what it turns out is, if you look at 24 weeks, which I've shown you, there's an average 80+% decrease in liver fat. I said the most you got out of tirzepatide was about 50%. If you look at 48 weeks here, you can see that it goes up to almost 90%. And if you look at complete, and I'll skip this for matter of, whoops, what did I do? I think the version, it missed a slide. One slide is gone here. Sorry, unless I have it afterwards. Nope, sorry about that. So what I showed in the next slide, the only slide that I'm missing, is the slide that says what percentage of people completely cleared their liver fat. And it was about 80% at 24 weeks and about 90% at 48 weeks. What it's telling you is that when you add glucagon agonism, you completely clear the liver of fat. What's the best predictor of improvement in NASH, including improvement in fibrosis, from a variety of other studies that I don't have time to show you, is how much and how quickly you clear the liver. And it's said that if you clear the liver more than 30% of fat, you're going to do well with NASH. Here we have a clearance of the liver of 100% of fat in 90% of patients. Now I just wanted to summarize then, and you can see I have no more slides purposefully, because what I want to now do is go back to bariatric surgery and say, why does bariatric surgery do so well? Here's a clear example where it may not be the weight loss alone, because the weight loss with tirzepatide at a year is as good as the weight loss of retatrutide at 24 weeks. It's actually better than retatrutide at 24 weeks. So what I would say is there's something about retatrutide that does something better, and we think we know what that is. That's glucagon agonism. And so it raises the question that we need to study, are the effects of surgery in fatty liver disease substantially more than the weight loss that we see? And it may be that we get to an answer for that faster even than we get to the answer for type 2 diabetes. Thanks very much.
Great, Lee. Great, really impressive. Ali, would you like to start?
Wonderful presentation, Lee. In terms of these medications, so there is no GLP-1 receptor on the hepatocytes.
Correct.
So, that's not, I mean, the effect that we see is not from the direct effect of medication on the liver, on the hepatocytes.
Except that there are glucagon receptors in the liver. So the effect, you could imagine even without receptors in the liver, you could have an indirect effect. You've got neural system, you've got endocrine system. So it doesn't have to be that the effect is directly in the liver. But the more important thing is clinically, you can never clear, no drug with only GLP-1 can clear more than about 70% of the fat under any circumstances that have been published. Whereas now we have, I showed retatrutide because it's the best of the ones we have. But there are at least 3 others that have glucagon, and they all clear greater than 70%. Some clear 70, this one clears 100, but you get my point. And that could be indirect, but we know there are glucagon receptors in the liver. So in glucagon's case, it could be direct. In the case of GLP-1, it has to be indirect.
But the point is that, I mean, you showed the fat clearance, percentage of fat clearance by these medications, but the semaglutide trial failed to show improvement in liver fibrosis. And as you showed briefly, liver fibrosis is the most important outcome for the NASH because it's linked to the hard clinical endpoints in the follow-up. So do you believe semaglutide failed to show improvement in fibrosis because of the shorter follow-up time? If they follow those patients longer than 1 year, they would see improvement in the liver fibrosis? And would you expect, again, similar findings with tirzepatide and retatrutide in terms of lack of benefit on liver fibrosis?
So what I would say is that we don't know the answer, but those studies are being done. They're being done with retatrutide, survodutide, pemvidutide. They all have glucagon. And those are the most promising ones because they have glucagon. We don't know the answer. I would have said in 2020 that we didn't wait long enough, it wasn't a long enough study, just as you suggested. I think now, probably if we wait longer, we'll get a better outcome. But there are now drugs, including a drug that's an FGF21, where you see improvement by a full stage within 24 weeks. A decrease in fibrosis, 1 full stage in 24 weeks. So you don't need to wait forever. And the only reason that we have that I showed the 6-year surgical data is because that's long data, so it raises the question you're raising. But you can actually remove fibrosis to a substantial degree in less than half a year. If there's a second drug, resmetirom, which after 48 weeks does exactly the same thing, it doesn't completely clear it. So I don't think that you have to have a long time. We now know that there are multiple drugs that can do it with fibrosis. This drug that I showed you does a better job of clearing fat than the other 2 drugs that I talked about. I show it because I wanted to make the point that there could be multiple mechanisms, some directed at weight loss, which could have a benefit, and others, and your question gets right at that point. Semaglutide is a great weight loss drug, but it may turn out to be a weaker anti-NAFL drug, anti-NASH drug, for the very reasons you're raising.
John.
Lee, nice talk as always. Quick question, as a hepatologist, is it physiologically good to get rid of 90% of the fat in your liver?
It actually normalizes. It doesn't get rid of every bit of the triglyceride in the liver. It actually normalizes. So I said it gets rid of it all. It means it brings it to what a normal liver has.
And as a surgeon, I'd like to ask you, so we should check out of our list of steatohepatitis as benefit from bariatric surgery?
No, it has clear
because of the drugs.
No, that's going to be a different question, which is the same question we've been asking this whole meeting, which is what do drugs do to bariatric surgery? And just to follow on, I can't stop myself from following on to what Carl said. We do have to do a better job of explaining to the world what bariatric surgery is and isn't. But I would argue, and I argued this in the Medtronic discussion earlier this afternoon, if we keep saying that bariatric surgery works the way we used to think it worked, we are actually shooting ourselves in the foot for the following reason. When you say that you are restricting somebody from their food, it is the moral equivalent of saying you are chaining them to the wall where the food, on this wall where the food is at the other end, and you're not letting them get the food. Number one, it doesn't work that way. And number two is if you say to somebody, I want you to do surgery, I want to do surgery on you because it's a great thing. But the process is that you are so bad at taking care of yourself, which is how they interpret what you say, that we're going to chain you to the wall, metaphorically. No wonder they don't want surgery. If we talk about surgery the way it is, a super powerful drug, which is really what it is, it's physiological, it's why it synergizes with other drugs, then the conversation is different. And I will tell you that the conversation that many of us who are not surgeons have with patients are much more positive than many of the conversations that some of our patients told us that they had with surgeons before they came to us. So I would say that it's not just science that we're talking about when we talk about the mechanism. It's how we communicate to the world. And I just make that strong pitch to the surgical community to join us in trying to communicate mechanism in a way that's clinically relevant to the people who are paying the bills, which is indirectly the patients.
Thank you very much.
My
That
pleasure.
was fantastic. Thank you very much. Now we're going to head with Dr. Rami Lutfi for the impact of bariatric surgery and cancer risk and its treatment. He's a clinical professor of surgery at Chicago Medical School and president and CEO of Chicago Institute of Advanced Surgery. Thank you.
All right, thank you. Very honored to be in this crowd. And I will tell you, probably despite the very high level evidence that was presented today, for me, it resonates the most, the messaging and the communication. As someone in private practice who thrives on the way we communicate with our patients, what a great thing of everything that was said, but the problem is we just keep talking about it among ourselves. We just need to talk more to the publics. This is my disclosure, my practice. So it's hard to have these slides without just having Ali on every single slide. You've done great work. So I tried to just give a little bit of everything in this very hard topic to unpack in 10 minutes. And this is one of the early papers looking at correlation between obesity and cancer, identifying 12 cancers that now we know are have very strong evidence to be related to obesity. But what's interesting in this paper is they showed for the first time that the risk of developing cancer actually increases with further weight loss. And they showed the difference between men and women, back to Lee's point or Carl about gender and the metabolic effect of obesity, and not only with the actual weight and BMI, but also with adiposity and waist to hip ratio in some of the fat distribution. Very, very interesting paper and findings. This is the Swedish study that was talked about a lot today that showed that surgery saves lives and a decreased mortality. I'm going to move forward here to the follow-up study to the topic I'm talking about, where they had excellent follow-up at 10 years after the Swedish study. And here is some findings that are a little different than what Ali will show a little bit later in my slides, that there was a significantly less incidence in the cumulative cancer occurrence that only reached statistical significance in women but not men, finding very different than Ali's finding, and maybe we'll let him comment on that. When they looked at the degree of weight loss, they found no difference, even in women with better weight loss having better improvement in cancer. And they did say that cancer incidence doesn't decrease, but only in women, not men. That was very interesting, something I did not know. Around the same time, the Utah famous paper as well. This one is a little different. They did not have their control being treated, and they just went backward with IDs and government paper to compare those who sought a treatment versus those who didn't. And they showed a survival benefit was great. And cancer was one of those that, this was one of the early evidence in cancer benefit in bariatric surgery, outside my topic, but it's always interesting to show that accident and suicide actually went up. But in the follow-up paper they had on cancer specifically, very interesting, showing that all cancer prevalence or occurrence did decrease in the bariatric surgery group, excuse me, the obesity versus none, but only in females again, and only in obesity-related cancer, but it was not significant enough to be present in all types of cancer. Interesting, when they looked at subgroups of stages, they showed that this is more in kind of mid to late staging cancer, but not in early cancer. But for me, the most important is that death from cancer actually was also different between males and females, but also was reached statistical significance even in all cancer when they counted not only obesity-related cancer, showing how the benefit in obesity-related cancer was so high that actually affected the overall group. Ali's paper, one of my favorite of his great work, interesting, this is him looking at the Cleveland Clinic database and how his brain worked towards the numbers that he chose to include, and showing again the obesity-associated cancer incidence with the great statistical significance, and also total cancer cases. And you see he maintained the difference in statistical significance, and very important as well here, looked between sleeve and gastric bypass, something that was not done before to my knowledge, and showed that no difference. And we're seeing more and more in this meeting a lot of good sleeve data showing that after all, at the end, there was no significant difference between sleeve and bypass. Very encouraging, as sleeve is very popular in the US. But here it's very interesting with Ali as well. This is obviously the weight loss over time. And here, this very nice finding and opposes many others in the past, that so Ali was able to show that the degree of weight loss did play a significant role as far as obesity-associated cancer. And what's interesting is when the body weight loss, less than 24%, you don't see much benefit, and the benefit really becomes significant with over 24%. So for me, it's intriguing now that we talk a lot about medications, and does that mean medications that cause less than 20% total body weight loss will not be as beneficial metabolically? No one knows. But certainly, this was very elegant graph to show the relationship as it relates to success of bariatric surgery or any other surgery that is metabolic. And Ali did come with pretty strong conclusion that I'm going to read. Among adults with obesity, bariatric surgery compared with no surgery was associated with significantly lower incidence of obesity-associated cancer and cancer-related mortality. Very bold, very good, yet very elegant. But I will spend 2 more minutes because this is pretty interesting to me, something I did not know much about, the impact of obesity on oncological surgery on survival. This is from, this is from the gynae, showing that there's increased risk of complications, something we know obesity is associated with, but no long-term outcome oncological difference in people with obesity. Some robotic people dispute that, saying if you, sorry, this is going quick, probably because we're running out of time. The use of the robot defeats that. Also, another one here showing in pancreatic oncology, no difference oncologically after surgery, but only difference with technical complication. Bunch of graphs here, you don't need to see them, but they looked at every single way to get any statistical, wow, sorry about that, any statistical significance. Anyway, in gastric cancer, they could not find anything. But this is very interesting. This is in colorectal cancer, and they saw something different. And they saw that BMI and weight did not matter, but they did a bunch of scans. I think the author were dying to get some p-values to get that published. But they look at the CAT scan and they get the ratio between visceral and subcutaneous fat and find that when that ratio was more than 50 percentile, there was finally evidence of a lower survival and oncological benefit of not being obese if we look at visceral obesity. So very, very interesting, I thought, and worth looking at as we talk about obesity and mortality. So in conclusion, obesity increases the risk of cancer. Now we can boldly say that to our patients. It increases perioperative risk on oncological surgery and may negatively, well, we don't know that for sure, affect the oncological outcome. And weight loss decreases all these things that I don't need to read in front of you, mostly in women, although Ali showed it in both gender. And I think now is the time, like many people said before me, to go to our patients and talk to them about those benefits beyond weight loss, as we said many, many times. Thank you so much for the time.
Thank you, Rami. Thank you.
Just a brief comment. Thanks, Rami, for a nice presentation. We have one more talk, and it's almost 6:05.
Yes, so, I ran through mine.
Since you asked me about the question, as you correctly mentioned, both in SOS study and Ted Adams' study, they showed benefit of bariatric surgery in terms of cancer risk reduction only on female patients, not male patients. But in our study, Splendid study, regardless of being male or female, we observe benefit in both groups. I think it's more related, that observation is more related to the statistical power and the design of the study, not the biology itself. We know that 80% of patients who undergo bariatric surgery and are included in those studies were female, and the two most common cancers that are studied in this literature are endometrial cancer and breast cancer that won't happen in men. So the sample size is smaller in terms of male patients, and the event rate is smaller because the most common cancers occur in women. So in SOS study, they had 2,000 patients in the surgical group versus 2,000 in the control group, 4,000 patients in total. But we had 5,000 in surgical group, 25,000 in the control group, 30,000 in total. So we had more patients and we had more events. So probably it's, again, more related to the statistical power and event rate, not the biology itself. Could be from the biology, but I believe it's more related to the design of the study.
Thank you.
Rami, fantastic. I had a contact like 2 or 3 weeks ago with a group of oncologists. They told me that they have a better, and this is published, I don't have the paper, but he told me, published that the response to chemotherapy is better on bariatric patients.
That's great.
Yeah,
we need more and more.
Published, but he told me, he said, we have better response to chemotherapy. I don't know if you read something about that.
Yeah, I think Dr. Morton presented yesterday that the response to chemotherapy is better. And interestingly, many
it's your paper.
I hear from our oncologists, Cleveland Clinic, that patients with breast cancer who undergo chemotherapy, many of them gain weight. So we always think that when patients go on chemo, they lose weight, but that's not true. They gain weight. So, and the breast cancer is linked to obesity. They gain more weight when they undergo chemo.
Now imagine if we publish this in non-medical journal and advertise this, how many people will be very interested instead of us just keep talking about it. Yeah. So thank you, but I know we need to move on.
Thank you, Rami. Thank you very much. We'll go ahead.
We have one more lecture, so please stay.
So now we're going to have a lecture about long-term mortality and bone fractures up to 38 years after surgery in a retrospective cohort. Dr. Lance Davidson, investigator of Utah University Study, Brigham Young University, and University of Utah. Thank you very much.
Thank you. I'm happy to speak here and honored to be speaking along with this great line of presenters. I I am an investigator on the Utah obesity study with Ted Adams, and his studies have been brought up here. I'm going to feature some of the mortality and also a bone fracture study as well, which could contribute to the discussion here, as some of the results are maybe not quite as resoundingly positive. But we'll discuss. Is that my button?
Yep.
Okay. Ted Adams and the studies here have been funded by NIH and a few other institutions, none of which should conflict with what I'm trying to tell you. I'm going to tell you a little bit of a story in this bit, and I was preparing for 7 minutes, so I had not seen that it was 10, so to your advantage. My first introduction to the Utah obesity study was Ted presenting this retrospective cohort study back in 2007, and I was impressed with the results. Was impressed that all-cause mortality risk decreased by 40%, 56% lower for coronary artery disease, 92% lower for diabetes, and of course we've seen lots of other studies that have given us similar results now. And the one thing that was interesting about that presentation, I still have not forgotten, is that accidents and suicides increased by 58%, and that was something concerning to me. I thought, how are they even related? And a few years later, I joined his team, decided I'd like to work with him, and we did a reanalysis of that data set, and we explored the effect of age at surgery on mortality, and divided them up into age categories and looked to see if there was a benefit all the way across from early age up to the oldest age. And we found, among other things, is the increase in accident and suicide mortality that was observed earlier was focused exclusively in female RYGB patients, which was surprising, again, that it would only be in that category. None of the other ones were significant and not even a blip up. It looked like the rest of the chronic disease categories. So a very interesting thing, and may give us pause to think about which patients we should be paying attention to. I shouldn't say we, I'm a PhD. We all should be paying attention to in follow-up and support after these surgery events. I am going to branch a little bit out. I'm just going to give you a few of the results that we have from our Utah obesity study, including the prospective trial, because there are some things that are interesting as well. Key findings that 12 years after the surgery in our gastric bypass surgery group, we had non-surgery groups as well, but the surgery groups were still 27% less in their weight on average. Of course, you can see this graph that I made up here. I wanted to show every single dot there so that we could see that it is not right along the line at 27%, but rather a smattering. And there are some people, only 1% of them that actually exceeded their original weight, which I thought was a good message for people to see. Also, approximately half of the patients with diabetes prior to surgery were still remitted at 12 years. Diabetes, hypertension, dyslipidemia, all were significantly improved compared to non-surgical controls after 12 years. That's a long time to be remitted, and it was right at 50%. In this study, we did have 96% follow-up, which we were quite proud of, but I think, though, that this study, although it's smaller numbers, we could combine with the rest of them as we're suggesting that we could probably come up with a mortality study at this point. Okay, Ted Adams and group, we've gotten together and extended and expanded our previous Utah obesity study so that we could look at longer-term mortality. We've gotten to 38-year follow-up for our earliest people. Of course, we've added new people along the way, so that brings the median year follow-up to 10.3 years, and also included more of the surgery types. We only had RYGB before. Matched with Utah driver license applicants, matching 1-to-1 on sex, BMI, and we included specific causes of death so that we could have more information on this study. And I will be showing you the results from 21,000 surgery group participants along with non-surgery group from the Utah population, and they were matched 1-to-1. Our key findings, and I'm not showing you all of them, but the key findings are these, and that is for all causes of death, it was 16% lower. We'll look at how it gets specific on the specific types. But under the non-external causes of death, we have cancer showing up at 43% lower compared to controls. Diabetes mellitus, 72% lower. And remember, this is much longer follow-up than previous. And major cardiovascular diseases, 29% lower. Interesting that patients who were more than 34 years old had this benefit, but our youngest group in this study tended to go the other direction for the mortality part. I think mostly due to an external mortality that was mentioned earlier. So those patients in the 18 to 34-year-old category had a 40% higher all-cause mortality and a 12% higher non-external cause mortality. I'd like to show you now the external mortality part. External cause mortality is the accidents and poisonings and suicides that, I don't know why we call them external, but there it is. That's how we classify it in the NDI. But suicide is the one I'd like to draw your attention to. When I was listening to Ted in that first talk, people were wondering, what's wrong with the people in Utah? Are they more suicidal? What's going on? As it turned out, Omalu followed up with a study right afterward to support that in Pennsylvania residents, so it at least spread the states. But this one continues to show up and is quite strong, as you can see, with 140% higher risk in males and females. So both were statistically significant in this one, and gives us pause to think about what is it that makes them a little bit higher, what can we do to change it, or can we support them better? Who knows, we need to get at the mechanisms, I think, but this is simply an observation that seems to not be going away as we extend. Now I'm going to jump just to another study that has not been published yet, but we're working on the outcomes, or working on writing it. Same study, essentially, with looking at bone fractures long term. Now, if you think about bone fractures, the heavier you are, the more you load your bones. And generally, you would think that as we increase in obesity, our bone fractures would go down, and they do, until we get to the severe obese category, and then it goes out the window. So you actually get a greater risk for fractures, and maybe it is the bigger you are, the harder you fall. It could be that, could be other things, insulin resistance, for example, with brittle bones. But we wanted to know if bariatric surgery is going to reduce all this weight, will it take that person's fracture risk back down into the normal weight category with that, and give them a benefit on fracture? So when we proposed this grant, we didn't know whether it was going to increase or decrease. And this grant actually came through 7 years back, and there have been other studies that have given us about the same result, and that is that fracture risk actually increases by 78% following gastric bypass surgery. The other surgery groups did not show up significant, nor were they even heading that way. So you did notice that we have fewer in the other categories. It could just be a statistical thing, but it could also be, as proposed by other researchers out there, that a malabsorptive surgery might do something. Now, I know that using the term malabsorptive is not a great thing, but if calcium is absorbed in that duodenum, then maybe there is something going on there we could discuss. That's all I could. I'll skip the fracture non-unions, and I'll leave those up while we maybe we could do a question or something. We'll be done. How about that?
Okay. Fantastic. Thank you. Thank you.
Great presentation. Thanks for sharing unpublished data. That was interesting. Actually, we have our long-term follow-up data of a stampede, and we observed the same finding that the fracture risk was higher in the surgical group than the non-surgical group, and that's interesting. So that's one of the adverse side effects of bariatric surgery that we learned in the recent years. Probably, I mean, one explanation could be related to protective effect of the adipose tissue around the bone. It works like a pad, and when we have a lot of pad, bulky pad, when patient fell down, then that's going to protect the bones when there is nothing there. So there's going to be more trauma, more severe trauma on the bones, and can explain the higher risk of fracture. But Lee and John, the two last questions.
Yeah, and you alluded to the fact with respect to the unique characteristics of gastric bypass. I'm not sure that it's only the malabsorption of calcium.
Absolutely.
There's vitamin D metabolism changes that are profound, much more profound in gastric bypass than the other operations. The comment I was going to make was about the suicide.
Yeah.
You had 44 suicides, it looked like, in the whole population, if I got that right. Or maybe it was suicides plus suicidal ideation. In our center, out of several thousand patients, we had 2. And we've had 2 so far. In those 2, one of those patients committed suicide 2 years after the operation, and the other one committed suicide 3 years after the operation. The operations were successful. They lost a lot of weight. And I think your point about support, it may be more than support. They may need very specific, intensive therapy for mental health issues. Just because you've lived for 40 years with obesity and you then take the obesity away, all of the mental health challenges don't necessarily go away. And I would say that 2 of the characteristics of these 2 patients whom I knew, because one of them worked in the hospital, was that they put all of their eggs in the basket of finally they're going to lose the weight and everything else is going to be resolved. And it took them 2 or 3 years to figure out that that wasn't the case, and that may be why it was so much later. But I just would emphasize that this issue, I mean, I love the fact that you parsed it out to a subgroup of patients, but even within that subgroup, maybe they're particularly sensitive to the description that I just made.
Yeah, absolutely.
John.
Well, Lance, thanks for all the work you and Ted have done to help support this field. Did I hear you say it's only the bypass that had the increased risk of fractures?
Yes. We did not have enough to study duodenal switch, which I think you were going to ask about.
Well, I was going to also ask about the bypass is also the one that shows the increase in suicides, not with the sleeve either. And I think the unifying theme there may be alcohol, because we've shown over and over again that alcohol metabolism is only altered in the bypass, not the sleeve. Could these fractures be harbingers of future events? Could you go back and look at the suicides and see if they had fractures that were higher than you expected?
Yeah, they're in the same data set.
So something to think about. It's something for us to think about. Like if we hear a patient fell, broke, we need to start worrying about that patient.
Yeah.
So, thanks.
I appreciate the connection.
Very nice, very nice. Yes, go ahead,
Real
Ben.
quick, Ben Clapp from Texas. I appreciate your data. I love it. I think we also have to remember about these suicides that 20 to 30% of our patients have PTSD from either childhood sexual abuse or childhood trauma.
Yep.
And so they're a high-risk population, and we don't stress enough psychological support. I mean, we make them see it before surgery, but maybe we don't make sure there's follow-up. So we tie a lot on it, and we're like, oh my gosh, it's causing this one. It's not. I think it's just creating a perfect storm to people that are already at risk that we need to be especially sensitive to. So thank you.
So about this is something that I believe all surgeons are worried about, the suicide numbers. And I do believe that maybe we should care more about doing previously the surgery, a best screening of these patients that should get more attention after surgery. I know there's a metabolic depression that covers it up, but maybe we should pay more attention. I have a psychiatrist that works with me. He's a very, very good guy on this. And we work a lot, and he says, oh, this one must come back. You have to put it on the red list so we can always go back to this patient to have have control of what's going on in his life. So I believe we have a responsibility, but I wouldn't put it all on the surgery. I would put it on all these factors you guys talked about.
Yeah, there was a great talk about body image,
Let me just
too.
ask one question from Dr. Kaplan. Is there any signal on these new obesity medication with increased risk of suicide? Any signal based on available data that we have with the new class of medications?
There's a very slight signal. It's in the package insert of some suicidal and self-harm ideation. There's been no evidence in any of the trials of somebody trying to commit suicide or trying to hurt themselves, but there's been ideation, and it got asked primarily because of the rimonabant history. I would suspect rimonabant is the opposite of marijuana, so it wasn't surprising that there could be that signal. In these drugs, it just may be that it occurs, but there's no specific mechanism that would suggest. And one of the points about the delay in the bariatric surgical patients that I've seen is that it seems very unlikely that it's a metabolic mechanism of the surgery itself. Why would it happen 2.5, 3 years later? I think that the same thing I would say about the drugs. There's no strong enough signal that would suggest that there's a direct effect of the drug on mentation in this regard. But we have to follow.
Yeah, I mean, we don't have the long-term data on those.
Exactly.
In the
We only have really about 25,000 patients so far who have been in these studies.
Okay, thank you.
Guys, I would like to stay here for like more 2 hours talking to you, but we have to finish the session. Thank you very much. I'm very happy being here with you guys. Thank you, Ali. Thank you very much.